right, good morning, everyone. It's a pleasure to be here, and I'd like to thank you both for the invitation to be part of this fantastic postgrad course. These are my disclosures, which will not impact the content of my presentation in any way. What I'm hoping to do over the next 15 minutes or so is review with you why qualitative assessment of enhanced recovery programs can be a useful part of implementation, and share with you some of our experience from the University of Toronto, and describe how we used this data to develop targeted implementation strategies of our ERP program in Toronto. I thought I would frame this by telling you how we started with our program. We had an ambitious goal of implementing a standardized enhanced recovery program across 7 of the academic teaching hospitals in Toronto. And one of the things we found very early as we tried to do this is people would say, well, we're already doing ERAS. That's a response that we commonly got. But of course, everyone in this room knows that ERAS is about a lot more than just feeding patients early and sending them out of the hospital on a certain post-operative day. And so we were able to get approval to do a small study that was going to be an audit of the processes that were happening in these particular 7 hospitals, just to give us a snapshot of what was going on. So we did a retrospective chart review, 50 patients undergoing colorectal resections in each of the 7 teaching hospitals, and we looked specifically at 18 ERAS components. And these are some of the results that we find, and the actual results are not that important for this particular presentation. Just to give you a few highlights, you can see that less than 50% used specific preoperative counseling around an enhanced recovery program. Very few hospitals had any type of intraoperative fluid restriction. And the point that I'm trying to make here is that this type of quantitative data is very useful, but it doesn't tell you anything about the why. Why is this happening? What are some of the local barriers and enablers that these institutions are facing as they try to implement their enhanced recovery program? And what might we be facing if we want to implement a standardized program across the entire city? And so this really led us to ask the question, well, let's dig deeper into these issues. Let's perform a formal qualitative assessment. And so this can be an important part of your implementation strategy, and a qualitative assessment for these reasons stated here can be very useful. Firstly, it helps you to better understand local barriers and enablers to what you want to implement. Recognizing that these are often multifaceted and a lot more complicated than they might seem at the surface. Importantly, doing this type of a qualitative assessment helps you engage with the healthcare providers in a way that you may not otherwise have the opportunity to do. And it's thought that it might help you predict their intention to change their behavior as part of the implementation that you're trying to make. And lastly, it can help you tailor strategies that address specific issues and can support successful implementation of your program. And so we embarked on this next study, a qualitative study, where the goal was to better understand the enablers and barriers to the implementation of our enhanced recovery program. So we conducted semi-structured, face-to-face, audio-recorded interviews at each of those same 7 hospitals. Importantly, we didn't only interview the surgeons. As you all know, a multidisciplinary approach to this is extremely important. And so we interviewed 3 general surgeons, 3 anesthetists, and 3 of the ward nurses for a total of 55 interviews across all the 7 hospitals. We asked them open-ended questions, not just about enablers and barriers within their own institution, but also specific questions to each of the interventions that we were considering. They weren't all ones that we were necessarily going to include in our program, but ones that we were considering and we wanted to get some of their input on. The interviews were all conducted by a medical student in person at the actual site where these individuals worked. So I'm going to spend the next few minutes sharing with you some of the data that we found from this qualitative assessment, starting by some of the main theme. Obviously, there's a lot of information here when you do these studies, and I've condensed just one particular theme down to several of the interventions, and I'll just highlight a few of them. When it came to patient education, pretty much everyone felt this was definitely an essential component to an enhanced recovery program. Looking at omitting a mechanical bowel prep, most felt that the evidence supported this, but that surgeon practice and surgeon preferences varied greatly, and that may be an obstacle. Preoperative fasting, again, the evidence seemed to support that, but there may be some surgeon and anesthesia resistance if we tried to do that. In terms of intraoperative interventions here, I'll just highlight intraoperative fluid management. Overall, if we wanted to do this, especially standardizing it across the university, this would be challenging and would require a clear evidence-based standardized protocol with widespread buy-in across the institution. And then just some of the post-operative interventions here. So you can see removal of the Foley catheter early. There was significant resistance from all respondents, interestingly enough. Mobilization, concerns about resources here. Everyone thought, yes, this is clearly essential, but there was concerns about lack of manpower and how we might be able to involve the patient and the family in this. Gum chewing, some interesting things that come up. Everyone thought this is easy to implement, but what about cleanup? What about the cost? These are some of the concerns that individuals raised. And then these are some of the other ones where there didn't seem to be, according to the people that we interviewed, they felt there was not enough evidence for their use. This is not to say that there wasn't, but this was the feedback that we got when we interviewed them. I'm going to share with you some specific discipline facilitators and barriers. So when we spoke to the nurses, some of the key themes that came out is that patient education is an essential component. This was a very common theme. They were concerned about specific patient preferences and needs. Manpower and resources, again, came up as a key nursing theme. The nurses felt that the surgeons would be resistant to change. They also had insight into their own practices and felt that they were resistant to change, and that education would be a key way to helping them do that. I'll just show you some illustrative quotes from our data. Education with nurses about best practices to get any of these new initiatives flowing, because you have to have nurses on board. Another nurse said, the number one barrier is that the nurses may not have enough time to get the patients up and moving about. The surgeons often aren't all in line with each other. Different surgeons from different groups have different ways of doing things. When we spoke to the anesthetists, some of their facilitators and barriers was that there was tremendous variability in practice across the department. Again, we would require protocols and guidelines, pre-printed orders. One of the main themes that was interesting was that they really valued the opportunity to have increased communication with the surgeons. They felt that this would be a way that the surgeon and the anesthetist could really speak and communicate around each case in a more deliberate fashion. And the anesthetist felt that nursing culture and surgeon resistance may be a barrier to change. And then lastly, the surgeons, they felt that new interventions would be easily implementable as long as they're based on best evidence. Again, wanted guidelines, standardized order sets. One of the interesting concerns from surgeons was that they were worried about discussing a specific date of discharge, because if the patient wasn't discharged on day 2, for example, after a lap right hemi, that the patient would be disappointed if they didn't meet that date, and it would somehow reflect badly on maybe what the surgeon did. The surgeons, this may be more of a local concern within our own context, but the shortened preoperative fast, if there was any change in the order, if one of the surgeons, if one of the patients was going to be started early, there was a concern that the surgery might get canceled if they had not fasted more than 2 hours. And then lastly, nursing culture and lack of nursing time were thought to be barriers. And again, surgeons recognize that they do have personal preferences and are often resistant to change. A few more illustrative quotes. It has to be multidisciplinary. You can't have one person or one specialty dictating the terms for everyone. Without institutional buy-in from the 3 departments, it's doomed to failure. And lastly, we should have done it yesterday. I mean, the data are really clear, and so I think that we should just move ahead. So just to summarize, some of the most commonly discussed enablers were that it has to be multidisciplinary, We need hospital and discipline champions with standardized protocol based on best evidence, pre-printed, pre- and post-operative order sets, and education was key for the perioperative team, patients, and families as well. And then some of the most commonly discussed barriers: lack of manpower, hospital resources, and buy-in from the hospital, poor communication amongst the team, and physician preferences and patient factors. So having a better assessment of the barriers to knowledge use, this is the often quoted knowledge to action framework. We're now in a position to better select and tailor implement interventions. And so I'm just going to share with you how we use this particular data within the context of our own program. So the first thing we did is that we developed our own evidence-based guideline, and this is on the SAGES SMART website, along with, I think, several of the other hospital guidelines, so you're welcome to download it and use it or modify it. We developed a guideline specifically for enhanced recovery after surgery, but also a separate postoperative pain management guideline that was developed by our anesthesia colleagues. It was done by the whole multidisciplinary team. We did a systematic review of the literature, and we didn't only choose the ones that had the best evidence, but also took those that we thought would be feasible to introduce using some of the data that I showed you across all of the 7 hospitals. It was circulated to all the stakeholders, and we reached consensus, and it's now been implemented. We did identify anesthesia, nursing, and surgeon champions at each of the site, and we think this is a key thing to do. Each of the champions is expected to assist members within their groups and liaise with the IERAS steering committee to ensure and help implement all of the recommendations. We developed communities of practice. So what are those? They're groups of people who share a concern, a set of problems, or a passion for a topic, and who deepen their knowledge and expertise in this area by interacting on an ongoing basis. So at a local level, this can include things like rounds, in-services, posters, team building activities. But we also did this at a provincial level. After we implemented it across the 7 teaching hospitals, we've now implemented it across 15 academic teaching hospitals across the province. And so we have meetings throughout the year of the champions across the entire province. It includes conference calls and an annual workshop. Very briefly, we developed educational tools and materials for patients, a book, a video, clinical tools for the team, especially the residents, so standardized orders, clinical pathways, and contingency plans. Engagement of residents. We have an app that you can also download off of the iStore. If you search for BPIGS, it's not the best acronym, BPIGS, Best Practice in General Surgery. It's one of the overarching initiatives that was developing this ERAS guideline. So there's other pathways there. But we thought the app would be very important for engaging the residents that at the end of the day are really providing a lot of the care, certainly on behalf of the surgeons on a day-to-day basis. Audit and feedback we thought would be important to help increase compliance and engagement, but not just sharing the data with the surgeons again, sharing it with our nursing and anesthesia colleagues and with the administration also. And that brings me to the last implementation strategy, which was, one of the key themes, again, was resources, lack of resources, and getting institutional buy-in. And so at all the hospitals, the steering committee or one of the representatives would meet with the champions, with the hospital administration, if possible the CEO, to actually get their support, try to get some funding for and dedicated time for the champions. And this was really a powerful way to demonstrate to the frontline staff that you had institutional buy-in and that this was an important initiative that the institution believed in. These are the 15 hospitals now that we've implemented our IERAS program. And so just to summarize, understanding and addressing local barriers and enablers is essential to successful implementation of your own programs, and certainly was in ours. A qualitative assessment is a useful approach to doing this. It's very useful in terms of engagement of the team as well, and it can help you tailor strategies that address specific issues and can help you support successful implementation. I'd be remiss not to acknowledge Robin McLeod and Marianne Arts, who have been integral to our program in Toronto, and there's the link on the SAGES website. the SMART program. I'm sure you've seen this already, where you can download ours, but many of the other ERP programs as well. Thank you very much.